Hello, I'm Dr. Christopher Thompson from Boston, Massachusetts, where I'm the Director of Endoscopy and the Co-Director for the Center of Weight Management and Wellness at Brigham and Women's Hospital and a Professor of Medicine at Harvard Medical School. And I'd like to thank Drs. Gaudat and Khawaja for the kind invitation to participate in this year's IBC at the Egyptian Society for Bariatric Surgery's annual Congress. I do hope that I could visit in person sometime soon. I've been asked to speak about the endoluminal management of fistula and leaks following bariatric surgery. And it's good to start with some background. And a fistula is, of course, an abnormal connection or passage between two organs or vessels that normally do not connect. And a leak is a fistula to the peritoneal or thoracic cavities, sort of a type of fistula. These can be categorized in several ways, including chronicity, etiology, location, and severity. Chronicity is perhaps the most useful way of classifying these defects, as it has direct bearing on the choice of therapy. As you can see here, an acute leak is classified within the first 7 days post-op, early leak within 1 to 6 weeks, late after 6 weeks, and chronic after 12 weeks. And acute and early leaks, patients tend to be more critically ill or septic, and the defect itself is usually more responsive to closure techniques. Whereas late and chronic leaks, patients typically are medically stable, but the defects are more challenging to close. Leaks can also be classified by etiology, with iatrogenic being one of the more common, post-surgical, post-procedural. Typically, post-procedural are considered perforations. Inflammatory, such as what can be seen after IBD, diverticulitis, or pancreatitis, and malignant fistula and leaks as well. They can also be classified based on severity, and factors that are associated with poor outcomes include a large size with an opening greater than 1 centimeter in diameter and a short track of less than 2 centimeters, distal obstruction, persistent infection, or high output fistula over 200 cc's per day. It can be challenging to diagnose a leak, and you must have a low threshold of suspicion. Clinical signs are often nonspecific. They may present without fever, leukocytosis, or pain, and tachycardia is the most common and earliest presenting sign, and it's present in up to 92% of patients. Nausea and emesis is common but nonspecific, and you may or may not have increased drain output. Upper GI and CT scans have a sensitivity of only 70%, so not terribly reliable. Methylene blue swallows can be useful if drains are in place, and an elevated C-reactive protein can also be suggestive. As part of a general management strategy, drainage is of course critical. Whether it's surgical, radiologic, or endoscopic, you have to get control of that. Important to start off being NPO, but enteral feeds should be administered distal to the leak site as soon as possible, as nutrition is important to healing, of course, and you can also consider TPN if distal feeding is not easy to achieve. We must correct electrolyte abnormalities early on, and later if there's been problems with prolonged inability to eat, and of course consider antibiotics in that acute phase. It's also important to determine the exact site of the leak. And in the gastric bypass, there are several different options. I have listed 7 here. They can be off the gastric pouch staple line or the gastrojejunal anastomosis. These are type 1 and type 2 leaks. They represent about 80% of leaks overall, and they carry a 9% mortality. Type 4 leaks are down at the JJ anastomosis, and these are rare, but they have a much higher mortality rate as they're hard to diagnose and hard to treat as well. Very hard to get a stent or something in here to cover this up. And the remainder, type 3, 5, 6, and 7, off the blind portion of the roux limb or the remnant stomach, again, can be hard to localize, and they carry mortality rates as high as 22%. It's very important to figure out where the leak is coming from, because you don't want to just stent across the GJ anastomosis if the leak is down at the JJ. Okay, that leads to very poor outcomes. So it's important to make the correct diagnosis before you proceed with treatment. Sleeve gastrectomy leaks are a bit easier to deal with. The vast majority occur along the proximal sleeve up at the staple line here at the top. There's a 1 to 3% leak rate and a 9% mortality rate when someone does develop a leak. So still something very serious to deal with. And distal stenosis is also very common and should be addressed. There are several different endoscopic management techniques, as I've broken down here, including exclusion techniques, such as the use of covered stents, closure techniques, including hemostatic clips, endoloops, cap-mounted clips, and suturing, occlusive devices and sealants, including septal occluders, bioprosthetic fistula plugs, different types of glues, and then internal drainage techniques, including incision and drainage, pigtail drainage, and vacuum-assisted closure devices. So I'm going to cover many of these. I'll talk about covered stents. As far as closure techniques, I'm going to focus mostly on cap-mounted clips, as they tend to be a good balance between actually being effective and easy enough to place. We'll talk a little bit about suturing. As far as occlusive devices, we'll touch on septal occluders and bioprosthetic plugs, a little bit on the adhesives. And then with internal drainage, we'll focus mostly on pigtails and vacuum therapy. However, we must first discuss the initial steps in endoscopic management. And these procedures must be done under general anesthesia with fluoroscopy and CO2. And if you have an external drain or connection, it's important to inject contrast and methylene blue into that externally and look with a scope for the bubbling methylene blue and look under fluoroscopy to track it down so you know exactly where that's coming from. Then you remove any foreign material, very important. Also dilate any strictures that are downstream, remove any drains that might be poking through. You got to clean that area up so it can be addressed appropriately. Confirm there's adequate drainage. Drive out into the cavity and look out there. Remove any foreign material out there. You can find gum and food debris, and you should remove that as well. And then you've prepared that area so that you can proceed with treatment. With sleeve gastrectomies, it's also very important to treat that distal obstruction. It's more common than you think. And even if it doesn't look like it's stenosed, it probably is. So if you have a proximal leak in a sleeve gastrectomy, I tend to dilate distally anyway. If it's very early, I'll use a CRE balloon and go no higher than 20 millimeters, maybe 18 millimeters. And if the sleeve is mature and the procedure is greater than 6 weeks previous, I will consider using a 30 millimeter pneumatic balloon. Moving on to treatment modalities, and first we have covered stents. And there's different types. There are partially covered stents and they're fully covered stents. The partially covered stents allow ingrowth, which can help minimize migration. However, they can be more challenging to remove and lead to kind of fibrotic rings and potentially dysphagia. So I prefer the fully covered stents. And if I'm having issues with migration or I'm worried about it, I might put overlapping stents or suture it in place. This is a meta-analysis kind of from early results, but more recent studies have proven this to be true. You can see various studies, very small numbers here, but across the board in early gastric bypass leaks, there's about an 88% success rate, and there's about a 20% migration rate, again, which can be addressed by suturing those stents in place or putting overlapping stents in place. But 88% success rate for early leaks in gastric bypass is fairly good. What about the use of clips? Well, this is a cap-mounted clip, very similar to a Variseal banding gun. And this is made of nitinol and is placed on the tip of the endoscope. And here I'm closing a gastric fistula, but it's similar to what you do for a leak. And I'm using a twin grasper. So this has kind of a little arm that comes off of both sides of the device. And then you grab opposing margins of the defect, pull it into the cap and suction, and then turn this little handle to release the clip. So this was a multi-center study that we participated in. 188 total subjects. It was retrospective. You can see in this patient with the GG fistula, it worked quite well. We're putting contrast in to confirm closure. You see it looks good. So in this case report, or case series, there were 32 leaks, 108 chronic fistula, and 48 perforations. Overall success rate was 64%. It was 80% for the acute leaks, which is good. 45% for chronic fistula, and 95% for perforations. The problem is they can be hard to remove. There's special kits to do that, but they can be hard to remove, and additionally they can be hard to place directly over the leak site. So I tend to do it over a wire and then pull the wire out at the end to try to improve my chances of success. What about gastrogastric fistula here and suturing? Well, this was one of our early reports on this. We published back in 2010. We had 95 consecutive patients with gastrogastric fistula, similar to the one we see here. I'm ablating that with APC, and I'm going to suture it closed. And the early ones were done with a barred endocinch device, which is no longer available. And we had a 95% initial closure rate. However, 65% reopened at an average of 177 days. So predictors of failure here was a large fistula, actually greater than 1 centimeter, which was probably the worst. No fistula over 2 centimeters actually remained closed. Now we've improved on that technique considerably, and this is a retrospective series, a comparison of 41 patients. You see our more modern technique here, where we actually perform an endoscopic submucosal dissection, and we'll remove any foreign material in there. And then we might even do a full thickness resection, which I think we show in this video clip, to try to remove any of the scar tissue right in that staple line, and then we'll suture it closed. So we compared this new technique to a technique of APC and suturing, similar to what you saw in the prior video. There's 30 patients underwent the APC technique, and 11 underwent this ESD fistulectomy seen in the video. So the traditional endoscopic approach led to a success rate of 20% at over 10 months, whereas this new modified technique that you're seeing here led to a success rate of 56%, and that was statistically significant. Moving on to occlusive devices, next we have the septal occluder. This was originally developed as the barred clamshell in the late 1980s. And it was a stainless steel device with a polyester coating, and it was used, of course, to treat intracardiac defects, atrial septal and ventricular septal defects. Newer versions are made of nitinol wire mesh, and they're encased in Dacron fabric, or a thin polytetrafluoroethylene membrane. And there's several different versions of this now available with different shapes and sizes. So it's very helpful for us when we're trying to close a variety of different fistula and leaks. This is the delivery system we create to do this, because keep in mind these are vascular devices, so they don't fit down an endoscope. The endoscope's too long. So what we do is we'll take a delivery catheter for a plastic stent. This is an Oasis system. We'll cut it. You still want to keep it as short as possible. We cut it to the length of the endoscope here. We'll then run a forceps down. It's a pediatric forceps, and grab the occluder device with that forceps, and then backload this, kind of pull it into the stent delivery system. So now we can really place it anywhere the endoscope can go. And here's an example of a fully endoscopic approach. We're spraying the occluder with a little bit of PAM to help it go into the system, especially if we're dealing with a large fistula and it's a larger occluder device. Now we're going to drive down with the endoscope to the level of the fistula. And in this case, we're dealing with, I believe, another gastrogastric fistula. However, we use this for leaks very effectively as well. We're placing that catheter into the defect, and then we'll push the forceps out, releasing the distal flange. You can do this under fluoroscopy, but it can be hard to see. We generally kind of have done enough of these where we can tell by feel when the first flange releases, and then we'll pull back and release that second flange. And you can see that's the forceps holding on to it. And with a very short period of time, this starts compressing the tissue. You can see how very nicely this seals a fistula. So we've published on this, of course. This is a series of 43 patients. 31 had sleeve gastrectomy leaks, and 12 had gastric bypass leaks. 3 were acute, 5 were early, 23 late, and 12 were chronic in this series. 40 had failed previous endoscopic attempts. Follow-up was 34 weeks. Technical success was 100%, and the clinical success was 90%, which is fantastic. And we found that really it does work better in chronic leaks. It doesn't work as well in acute leaks, perhaps because they're more elastic and the occluders are more likely to migrate in those cases. So success rates for late and chronic leaks was 97% versus only 62% for the acute leaks. And here we're moving on to endoscopic vacuum therapy, EVT. And here you can see we're using an NG tube and we're placing an open pore polyurethane sponge onto this, and we tend to suction it on. We cut the NG tube and then we'll suction suture it a little distally and then suture it proximally. Now we've already placed the NG tube in the nose and pulled it out through the mouth. So now we just have to kind of pull it back into the mouth, chase it with an endoscope. So we're going to pull it back into the mouth, chase it with an endoscope down and get it in position. You can do that with a snare. So you can place this either intracavitary or intraluminal depending on how big the defect is. As it gets smaller, you're going to gravitate more towards intraluminal. And then it's exchanged every 3 to 5 days, no more than 7, or you can get ingrowth into it, and then really you run the risk of having substantial hemorrhage in those situations. There's several mechanisms of action here that were really well defined with external evac therapies, and micro and macro deformation, really kind of pulling in and collapsing that tissue. Increased perfusion. Initially, it was kind of decreased perfusion. You have release of 1-alpha and other substances and chemotactic substances, which end up leading to increased blood flow and actually increased vascularization in the area. Of course, you get good exudate control with that negative pressure and suction and bacterial clearance. Now, I like this image to remind us that this was first used actually in colorectal surgery leaks back in the early 2000s. But this is a retrospective cohort study with multivariable regression looking at intrathoracic leaks. 39 of these patients had SEMs or SEPs, so self-expanding metal stents or plastic stents, and 32 of these patients had EVT. So the closure rate was significantly higher in the vacuum therapy group at 84.4% versus only 53.8% in the stent groups. Successful wound closure was independently associated with EVT therapy, and there's no difference in length of stay or hospital mortality, and significantly more strictures were seen in the stent groups. So again, EVT was found to be effective. And this was one of the larger studies. You see several smaller studies in bariatric patient groups with similar outcomes. And finally, we have pigtails, and there's really nothing new about these. We've been draining pancreatic fluid collections for decades, and we'll go out, we'll explore the area, and that's just how we treat pancreatic necrosis. And this is a very nice series showing a technical success rate of 98.5%. This is in 67 patients here, patients did very well. The take-home point here is these only should be done when you have a walled-off collection. You don't want to do this in an acute leak where you're in the open peritoneum. You want to wait till it walls off, and then you can get good results. Average of 3.14 endoscopic sessions. So general guidance here: things you want to think about. Chronicity. So if a leak is acute, you want to cover it up. You might want to try to close it with some clips or some suture. So if it's acute, that's going to be the approach. If it's chronic, then you can consider draining it with pigtails or maybe evac or plugging it with an occluder or other device. Location is also important. If it's in the esophagus, it's very accessible for evac or pigtails, even in the stomach. If you get down in the small bowel, it can be harder to reach these things and certainly harder to get a cap-based clip on. Maybe you're using hemostatic clip. Size is also important. If it's very large, it may be more difficult to close with an occluder, perhaps, or cover up with a fully covered stent. Tissue quality: you can't really suture an area if the tissue quality isn't good, so you might consider using an occluder there or using evac or EVT therapy. Tract length: you can't glue a short tract. We know that. And margins are also important. So things to consider as you're trying to choose the optimal therapy. In conclusion, Anatomic features and chronicity must be considered in selecting the best therapy for fistulas and leaks. Covered stents are most effective for early gastric bypass leaks, less effective, I think, in sleeve gastrectomy, where you're just trying to get it to go chronic safely. And that's where pigtails are very helpful and most commonly employed, and walled off leaks following sleeve gastrectomy or potentially gastric bypass. So two most common ways of treating. And then septal occluders and EVAC or EVT are effective in the treatment of chronic fistula. And these are typically reserved for critically ill patients or when other methods have failed due to either the need for many repeat procedures or expense. Thank you very much for your attention.